I thank Pune Urology Society for giving me this opportunity. Dr. Jaideep Dapte, President Sir, Dr. Ketan Pai, Secretary, Dr. Ketan, Moderator, and Senior Most Urologist, everybody knows Dr. Bapat Sir, and colleague speakers Tanuj Pal Bhatia and Abhishek Singh, and all the viewers. I have been given topic on RIRS difficult situations made easy, how to make easy. So flexible ureteroscope, as you all know that now part and parcel of every urologist armamentarium, technological advancements are reaching new frontiers, improved optics, deflectability, better ergonomics and reduced shaft diameters. Nightmare situations do occur which requires expertise to come. What do you do when you don't know what to do? That is my talk actually. Now, I will directly go to the clinical situation instead of going into the theory. Now, buckling of access sheath in urethra. First thing when you want to put in male patient like this, when you pass a guide wire, the urethral access sheath gets buckling. So in that case, you can use the ureteroscope along with the access sheath and then go into the bladder. This is like a visual operator method which you use all in TURP. So any scope will go into any access sheath if you have 4 by 6.5 access sheath. This is my first video. Now coming to the second video, if the narrow ureteric orifice is there, everybody asks whether to put a stent or not. For example, if you see here, this is 4 by 6.5 scope. You are going inside, it is very tight. Put a stent and come out. There is no tips and tricks, put a stent and come out. Now, if you are desperate to do a small stone, just you can keep the sheath above the UVJ. This is high risk, preferably not recommended. Better to put without sheath flexible scope, that is better. If you do like this, the ureter gets damaged like this. Most of the damages, if you keep 3 to 4 weeks stent, you will get away without any problem unless you have really damaged it. Because if you keep the access sheath here, assistant hand, entire ball goes into assistant hand. If she or he pushes, it perforates. So don't manipulate keeping the ureteric access sheath at the ureteric orifice. Now, if you have an upper ureteric stone, you are not able to go with a rigid ureteroscope, you can go with flexible scope. Ultimate idea is that either use pneumatic lithotripter or you push into the kidney and do RIRS. Don't do in between. But certain situations you cannot push. How to do? Then keep low energy, low frequency, pass a guide wire always, then come back again with access sheath. I repeat, come back again with access sheath. Why? Because water outflow will be good. Temperature will not rise. We have burnt our finger by using long time laser. If access sheath is there, see, vision is clear. You are using flexible scope. You do in the center part, as early as possible, push into the kidney. Don't try to be there for a long time in the ureter. See, now I have done little bit. It breaks into 2 pieces. Entire piece I am pushing in. I am very happy. I will sit in the upper calyx and nicely do RIRS. See, now it has broken into 2 pieces. It is going up. Let it go up. Let it go up. Push with flexible scope also, no problem. It won't get damaged so easily because the tip is very strong, but we don't recommend that. With slight water flow, it will go up. Now you do a formal RIRS. This is one point in the impacted stone. For example, you see bifid system, impacted stone. For supine PCNL, for prone PCNL, for ESWL, it is not suitable. How to do? Same point, pass a guide wire. If you cannot pass with rigid ureteroscope because there is a kink, RGP is the crux. If I have not done RGP, I might have not I might have not recognized this. Then I tried to pass a guide wire. If you pass the guide wire into any system, half of the work is done. At least you can stent and come out. I have taken a old scope. This is also important point, because in these maneuvers, you lose the scope. See how many dots are there in the periphery. Again, I am using in the center of the stone and pushing into one of the moiety. Now it has gone into upper moiety. Now I am going into the upper moiety. It is in a room. You do popcorn, you do dusting, anything, no problem. But ureter is protected. You go to the upper calyx, you go to the lower calyx, you put the stent anywhere, no problem, because junction will be dilated. This is one case I have shown. Now, stone is not accessible. You are doing case nicely. After removing some stone, it is not accessible to the laser fiber. As Tanuj Pal Bhatia told, 3 o'clock and 9 o'clock laser fibers will come. That doesn't mean that you will buy always. Very rarely in yearly once, you will see such a situation. Now, in this case, it's a horseshoe kidney. I went inside. I have seen the stone. I have passed the access sheath. With after passing the access sheath, I was doing with a scope nicely lasing. This is a Flex XC because it is interesting case. I was using digital scope. In digital scope, laser fiber comes at 3 o'clock. See, it is at 3 o'clock, but stone is at the 9 o'clock. I am trying to push. It is going into the cavity, excavate like an excavated cavity. I moved to P7 where laser fiber comes out at 9 o'clock. See the exact advantage. The stone is at 9 o'clock. Laser fiber is at 9 o'clock. Slowly you make powder. Suddenly that comes out of the calyx. Then job is done. So sometimes when stone is fixed, you cannot reach the 9 o'clock. You have to change the scope. So all disposable scopes, they have 3 o'clock, whereas fiber optic scopes usually at the 9 o'clock. This is one case. Now this is at the end of the surgery. Now coming to the large stone. You don't want to do PCNL. Large stone, PCNL is better, PCNL is better, PCNL is better. But you have gone inside. You have seen a nice stone like this, which you think that RIRS can be done. But after some time you realize that you cannot basket because infundibulum is not bigger. See, this is a big stone. If you do for 1 hour, flexible scope will get more dots. See here, there are 7 dots. They will become 9, 10 by next case. So what we can do is do a little bit. After that, assess the lumen and take the basket. Vertical length, you can put it in the upper calyx so that scope damage will not be there. The idea is that in the inferior calyx, make fragments, get into the upper calyx, happily do without damaging the. See, it is upper calyx. Anytime you, any amount of time, no problem. Now you powder, you fragment, no problem. You increase the energy laser, no problem. But inferior calyx in a bent position, you should not do that. Now, matrix stone. Everybody says that matrix stone, it is very good PCNL, correct. But in horseshoe kidney, with hemoglobin 7.8, severe pyelonephritis, recovered heart kidney, can you puncture for 1 centimeter stone? You will be afraid. So we, with our experience, thought, first I tried to take out small pieces. It will take 1 day if you take out all pieces. Then we tried lasing. It will not lase because laser will not function other than stone because it won't absorb the heat. But what we have done is make small pieces. Don't try to make dust. And put access sheath into the pelvis. Use feeding tube, suck. Now I am sucking all the mug through, like you PCNL, you suck it out. Like here also, large access sheath is present, very wide ureter. 2-3 weeks a patient was on stent. Now you suck out everything. After some time, only central core small stone will be shown. See, in horseshoe kidney, hemoglobin is 8, VIP patient, post pyelonephritis recovering. You puncture and deep dilatation. Sometimes it is difficult. We should not deny that. Now see, in the post-operatively, there is no stone, patient recovered. So matrix, if you can suck it out, for this one condition is must. Large access sheath should be in pelvis, no maneuvers after that, just go and suck out. You can't push everything. Recently, there is a one flexible scope has come, which goes inside without vision and suck out everything, but without vision it is blind, same like feeding tube. Now coming to the clots, suddenly you are doing RIRS, clot will form. What happens? You stop the procedure, you come out. That is best. Why? Because number of hours you spend, number of minutes you spend in kidney, you get infection, as our moderator told. But small clot, it is okay. How? This is the way. Clot is there, stone is there. Whatever stone you can see, you pulverize. Then you take the basket and take out the clot in one go. If it comes, okay. Otherwise, don't try 20, 30 times because more bleeding happens, more clots form, vision will be lost, unnecessarily water pressure will increase. One or two attempts, simple clot, you take out like this. N circle 2 centimeters is very good for this. It traps. See, the clot is coming out. This is a big clot inside, but outside you see as a small clot. Now clear vision. Now you do popcorn. So still one small clot is there. No problem. It can be taken out. So big clot forms when you take out the scope, when you put scope. Don't take out the scope when you are doing RIRS. No need to take out. Make powder. Last part only you take out. If you take out flexible scope, bleeding will occur. Like in TURP, when you take out the sheath, the inner part, till now you might have coagulated so much, but the bleeding will come. Now, frank bleeding, do you expect in RIRS? Very, very rare. I have seen. Why? Because of mistake. What mistake? Infundibular vessel is a very large stone in the upper calyx. Naturally, you try to do fast. This is a bifid large stone in the upper calyx. I tried to do fast, and when my laser fiber touched the infundibulum, it started bleeding. Don't think that the laser fiber cannot go deep. It can go deep in under vision. Then immediately I realized I lost my vision. See the bleeding. What can you do if this bleeding occurs? First thing is remove access sheath. If you put access sheath and water, 1 liter of blood also will wash away. There is no point. The only resistance that can come is pelvis and ureter. If you keep intact, then every drop of blood will come out. Don't keep flexible scope inside if the torrential bleeding is there. Remove the access sheath, pray the God. Why? Because angio also will not be of much help. If torrential bleeding happens, then God only has to save. That amount of torrential bleeding unlikely to happen with a small 200 micron laser fiber. Usually nature will protect. Now coming to the deep inferior calyx in solitary kidney, diverticular stone. So you want to do PCNL. If you do puncture, it is I stopped transmission. After I found the stone, I told to transmit. That is a fear we will have. If I don't see, small hole was there. In that, I kept the laser fiber more outside. Awkward maneuvers. This is not my scope at that time. Otherwise, this is a 14 lakh scope. Awkward movements I have done and made fast fragments. Fast fragments. And these are secondary stones. Get them out into an accessible calyx and then do popcorn. So secret is inaccessible areas, make fragments fast. Don't try to do dusting. Inaccessible areas, don't try to do dusting. So we are doing pediatric RIRS, pediatric supine PCNL. I'm happy that world's smallest baby bilateral RIRS is from Preeti Hospital because anuria. Similarly, world's smallest baby supine PCNL is also accepted from Preeti Hospital. And today only we got acceptance in International Journal of Clinical Urology laser settings. With this introduction, I am showing this 4 months baby. This is the smallest baby bilateral RIRS. Why we have done? It is bilateral ureteric stone with anuria. It is emergency. Stented. Can you remove the stent? No. You should do URSL. What about the kidney stones? ESWL. So because I am RIRS surgeon, I thought first I will do URSL. In the small baby, bilateral multiple stones, can ESWL be easy? No. So with my experience, these are the multiple stones. This is the small penis. So this is the video. I will go fast. There is nothing great here, but technically difficult. The point I want to emphasize is always stent. Always stent. Don't pass the access sheath in small children, especially male baby, because urethra you cannot make big. Ureter you can make big, but urethra you cannot make big unless you put a Foley's catheter before. Second thing, pass 2 guide wires. Even after passing 2 guide wires, I had difficulty. Empty the bladder by suprapubic catheter, just intracath. Now see, I am not able to pass the flexible scope. After that, I passed again scope. Then I went inside with merge maneuver also. Right side, I finished RIRS. Fortunately, it went well. Then I went left side. This is a small stent. Every step is difficult. Do RGP at the end. Document any complication that happened. Now this is the other side. I am doing again ureteroscopy, removing the stent, pass 2 guide wires up to the kidney. Then only you do the case. See, this is upper ureter, not going. High maneuvers in the lumen is essential not to damage the ureter. See, suprapubic, within 1 minute, the bladder will fill in children. This is 4 months baby. Ultimately, I could go inside. Every calyx had a stone, 4 months. I don't know, metabolic workup has shown hyperuricosuric urine and raised uric acid. This baby is now 1 year. She is on allopurinol, he is on allopurinol, no recurrence of this stone. This is one of the rare case. See the nephrogram phase. On the right side, nephrogram has not seen, but left hand nephrogram is seen. That means intravasation has happened. This is the post-operative CT. Now, coming to the horseshoe kidney where stone is hidden. You are able to see, but your laser fiber does not touch. Is there any trick? Is there any trick to get it out? Yes. High frequency, if you use, for example, you see in this video, I am showing high frequency. This is a ischemic stone. See, small baby, around 8 years, male baby. I have done nicely the stone, but in the isthmus, I am not able to go. What I have done, I kept high frequency, 30, that time I had 60 watts quanta. When the stone comes out and hits, comes out and hits, comes out and hits, now I am able to go into the calyx. So whenever you are seeing the stone, it is slightly mobile, put high frequency, it will move. This is lifting effect. The stone will move and come in touch with the laser. Now coming to ECIRS, my talk is approximately, I have done 12 minutes. Now another 8 minutes is there for me to talk. ECIRS, why it is useful? After doing so many RIRS, when I am doing large stone, I am losing money, I am losing time, I am not removing all stones. Then I thought, why I should not do supine PCNL? Because of the large stone. Now I will show 2 cases where it is useful. See, these are the multiple stones. Am I audible?
Yes, Chandrama.
You are audible.
Sorry. So there is an upper ureteric stone, 4 stones. What surgery you can remove all these? PCNL, but 2 punctures, 3 punctures may be required. Sometimes you may get away with mini nephroscope. Why not ECIRS in this case? Now, see, this is the position of the supine PCNL. I am not going into the detail. It is well established. By 2007 only, Nadiad has published the paper. Posterior axillary line, 12th rib, two important this thing, stay below them, you will be very safe. Now this is a calyx, very easy case for PCNL, provided you can reach all the stones. If you cannot reach, that's a difficult. See, I have punctured the supine, then the puncture can be seen nicely from the calyx, so that bleeding chances are very less. Now one person, the access sheath is inserted and the stone is removed. One stone is not getting from this supine PCNL also. Then see, from below, RIRS surgeon has come and finished that. This is the advantage of, see the scope and parallelity of the flexible scope. If you have multiple stones and a very large stone, ECRS is indication. Take all these stones. See this video very fast. I will fast forward.
Gentleman had come to us with left.
See, this is the CT. This is the CT I have shown. This is the CT I have shown. This is the X-ray. This is the position. Only thing is that there should be some space between the legs for the RIRS surgeon. You put access sheath before, no problem. Access sheath acts as a RGP injecting agent also. Instead of ureteric catheter, you put an access sheath with the inlet also in. There will be a flushing cannula. So now you have entered, you go inside and see the stone dilatation, protein, everything is same. You do the dilatation, you go inside. Now the stones are picked up. Now the stones are picked up. All the thing is over. Now see, the flexible scope has come in and he is doing the job. Infundibulum is narrow. That's why he is doing powder. These small fragments you can take out from the access sheath. These are the small indications. Now next case is a beautiful indication. This is a post-operative picture to know supine PCNL tract. This is the contrast. This is the contrast injected through the nephrostomy tract way below the colon. Now next case is interesting. True case for RIRS. See, anybody, if you see this, nobody says, what is this easy case? Just supine prone PCNL, you give me half an hour, I will finish the case. But see the RGP and comment. This is RGP. Now what will you say? Many people say, I can go with mini nephroscope from below to above, but you may not be able to. In that case, what will you do? You have to do supracostal. Where is the supracostal here? Above the 12th rib. That means your puncture is supracostal. What will happen? Nothing will happen. But is there any alternative? Yes. You see in this video, this is a puncture where I have to do 2 punctures and then also flexible scope helped. I will show the video. This is the video. I will show entire video. This is the video. Now after this, not much interesting. Don't worry.
Here is a case of
finish in time, maybe another 5 minutes. This is the CT picture. CT and plain X-ray will never give the plan because we are avoiding IVP. If we have done IVP, we might have planned very well. Then RGP has shown bifid system. It may be easy in prone PCNL also, but why not have an access from below? See, now I have punctured. I thought I will go from above or below in the lower calyx. I have gone from above. Unfortunately, I have gone from middle calyx. I have gone inside, removed a lot of the bulk of the stone. The advantage is you can flush from below. All the gravity stones will come out nice. So far it was nice. You remove as much. Now I am not able to go into upper calyx. I have a small nephroscope. I have removed the sheath. Still I am not able to see the stone is seen, but it is very tight to go inside. Sometimes infundibular tear can occur. Upper pole infundibular tear is unacceptable. And what is the greatness in forcibly going there? Then I went with flexible scope. I made pieces. There is no need to do powder. Don't think that it will take long time. Make pieces, take the Dakota basket and give it to the PCNL person. He will take it out. Big fragments. See, here I am fragmenting, no dusting. High energy, high frequency upper calyx. Make 4 pieces. Give the 4 pieces to the PCNL surgeon like this. Give him, he will take it out. Finish. Even then, one small stone was there in the middle calyx. See, how can you remove it? It is just next to ampulla. Sometimes people will come out and do maneuvers. To some extent, okay, but not always. But if you have a flexible scope, finish that small stone into pieces and give to the nephroscope person. After this also, inferior calyx, one small stone was there. What you do? Don't do dilatation. Do only 7.5 French nephroscope, push into the pelvis and remove from other nephrostomy tract. This is all to minimize the dilatation in the kidney. ECRS is nothing great. Supine PCNL is only added this thing. Now everything is cleared without much. If you are in prone, you have to leave or you have to puncture 3 times. Some people say, I can easily go into upper calyx, but in supine also you can go into the upper calyx easily because it is a long horizontal tract. Now last case is simultaneous bilateral endoscopic surgery. Everybody wants to know latest things. We also had one case. What is the true indication? Everyone says, why 2 surgeons? Why 2 laser missions? Why 2 one Facebook comment has come. Are you treating guinea pigs? How can you operate on both the sides? The answer is, the Gudo Gusti has written a paper, professor. He has done already 50 cases. We read that paper. We thought we are doing routinely RIRS. We are doing supine PCNL. See, this is the case. If you have a large stone one side, if you have a small stone one side, patient is an antiplatelets. He cannot undergo anesthesia and again. He is a sick patient, cannot be tilted back, 40 ejection fraction, one small stone on the left side, one big stone on the right side. Big stone I am doing supine PCNL. Small stone other person will do RIRS. Normally we have 2 theaters. Normally we have 2 monitors. You may not have 2 laser missions, but why you need laser mission for PCNL? You put access sheath before on the other side. Is there any wrong? Nothing wrong. Only culture should be sterile. If the culture is sterile, one side person will do the PCNL like this. He punctured. I was doing supine PCNL. I went inside. This is a suction super perk from Kaushik Shah. And then I used initially laser. After that, I shifted to pneumatic lithotripter. Now other person started doing small stone RIRS. What is the advantage? Total duration of surgery is 20 minutes. 20 minutes only in general anesthesia. This is the left side RGP, right side PCL. So this is almost my talk is over. Next 2-3 cases, because I have 2-3 more minutes. I finished around, I started around 35. Now another 2 minutes are there. Failed basketing. See, if you failed basketing, this is entrapped basket. I might have shown before also. Don't underestimate the stone size by CT. CT always says it is a small stone. You should not get trapped. I got trapped. Stone is not coming. Basket cannot be detachable. What will you do? You cut the basket, 7,000 gone. You go by the side of the, this thing. Then you go inside, see the stone and you use the laser. Is it easy? No. Because you are continuously applying traction. So your maneuverability is less. Then you touch the basket. Then basket broken. 1 piece, 2 pieces. If 4 pieces are broken, removing that is a difficult. So PCNL. So there is no one procedure, both are complementary. You have to do PCNL. I feel PCNL is a must surgery in urology as of now, especially if you are doing high volume, large stones. There is no replacement for PCNL sometimes. If you know very well, especially ultrasound guided PCNL, if you know 99% of the situations, we can at least get out of this situation. Now I was pulling the guide wire, it is coming kilometers. Why? Because it was uncoiling, dangerous. So I checked from antegrade, retrograde. Ultimately, I removed the basket. Now last case, RIRS and lap assisted PCNL. This is a big stone. open pyelolithotomy done by a senior surgeon. I was referred for the RIRS. I was crazy. I thought I will do RIRS, but I failed. I am showing in this how I failed. This video is not coming. That means video itself is telling that better not. After initial attempts, video is not playing. What happened is we could not do. We see this is the RGP picture where we could not do. Then we did laparoscopic assisted PCNL. Like most of you know, one important point I want to tell is whenever you are doing laparoscopy for a large stone, don't do pylotomy. Do laparoscopic assisted PCNL because you can go to all calyces. Here that made me helpful because it's a small hole. You insert the access sheet, go to each calyx and remove stones. At the end, you put 1 or 2 stitches. Unfortunately, I thought I will show this, but it is not playing. I will try once for my satisfaction. If it doesn't play, these are the rescue situations. Bias is coming,
sigmoid
but
colon is not there.
is not coming.
Flexible
So you
uterus.
never know unexpected situations like this. Simple cases may become challenging. Challenging cases require expertise. Difficulties can be made easy by only technical skill, by experience. Smooth seas do not make skillful sailors. See, I have presented very well everything, all my videos played, except my heart video last did not play. What I can do? I have to be next time prepared, check once again. In the middle of every difficulty lies some opportunity. Thank you very much for giving me this opportunity. My team always helps these 6 people, especially this presentation, Dr. Soundarya, who is female urologist from Chennai, working with me for 2 years, put lot of efforts, two days, gathering all my main important cases and showing this. Thank you once again for patient listening. Thank you.
Chandra Mohan, heartiest congratulations for all your achievements. Thank you so much. A few questions. You are doing the endoscopic assisted PCNL, so why not use a flexible nephroscope or a flexible urotoscope through the same channel and tackle all the stones together? Why not?
Sir, that is a very, very important question, sir. Very, very important question. Why conferences does not show flexible nephroscopy? Because your sheath, whatever sheath you keep, that will not allow the flexible scope tip to move. 15 centimeter has to be inside the kidney. Unless it's a large hydronephrotic kidney, you cannot do any maneuverability. This is with flexible nephroscope or cystoscope, I am telling. That's why everybody goes for puncture. Number 2, flexible ureteroscope will be kilometer away from you. You have to stand very distantly and move. If you move left, it will move right. Unless you have access sheath up to the stone point, you cannot use. That's why antegrade flexible scopy has not come into a big limelight because there is no holding factor.
No, I accept it for the rest of the cases, but the one where the upper calyceal stone was there and you went through the lower calyx, I think the flexible nephroscope would have walked in.
It would have gone, but flexible nephroscope laser usage is difficult. Only basketing can be done. Laser usage is difficult. For me, with my, even I am 16 years experience, I feel it is difficult, my opinion.
No, I just an additional comment.
Yeah.
And one more question to you. In case the situation is that you have lots of flexible urotoscopes with you and multiple access sheaths.
Yes.
So you will select the smallest possible access sheath?
Smallest, always smallest. By rule, smallest.
Okay. Do you feel that using the largest possible access sheath will help you in irrigation as well as removing the fracture?
It helps in irrigation in a large stone, post-stented, highly accommodable. Large stone you want to do 1 hour, pressure will not raise, water will be coming. In fact, water will not stay. You will have problems sometimes in collapsing of the kidney. So less than 2 centimeter, small better, but larger sheath, large caliber ureters you can identify, easily it goes, then finish fast.
Thirdly, in case there is a, say, 1.5 centimeter pelvic stone, and you could reach the stone by a semi-rigid urotoscope, you will go ahead with the semi-rigid urotoscope, or you will like to shift it to the RIRS?
I always like to use flexible scope because entire stone, sometimes what happens with respiration, with movements, after breaking half, you cannot play on the surface of the stone completely. So I strongly recommend use flexible scope because residual stones will be high. One small stone into inferior calyx, you think that you have nicely done, but next day X-ray will be seen 6 mm stone. You will be hurt.
In case you have to buy only one scope, what is your personal preference?
I will take like Tanuj told P7 or FlexX2. It is impossible to tell which is. I have three this, three that. Every alternate case I use. The FlexX2 is more durable. P7 is more visual optics. Very simple. One word. This durability is more, but optics are less. Whereas this is optics are better. Sometimes if you press, it will break. P7.
Mohan, few questions for you.
Yeah.
Pre-stented or it doesn't matter?
70% now, as my experience increased, I am stenting more. Previously 90% without stent. Now it is coming to 80, 75. Because it is my own hospital, I don't charge. I will always be safe because fever is a main problem. If tight ureter is there, if you somehow do it, you can do it, but patient gets fever, even if it is not sepsis.
Pre-stented is what you desire.
70% non-stented, 30% stent.
Preoperatively, do you ascertain a urine culture being sterile?
We send urine culture on with a surgical profile. Honestly speaking, I am not telling wrong. I will go ahead. Next day when he gets fever, by that time urine culture will be available to me. So before the day, when the first day OPD, we will send the culture.
Your method of sterilizing the P7
Now
or
I have
the
steroid. I have steroid, significant reduction, but doesn't mean that it is essential. Chemical sterilization is very good. Only problem is you should have a separate tray where entire scope dips. You should not keep the hand part outside at any cost. That is most contaminated part.
Truly speaking, you don't mind chemical sterilization
Yes,
as
sir.
against.
Worldwide recommendation steroid, but chemical sterilization 12 years I used. I was 5 to 10% fevers used to come. Now it is maybe little less.
Post-op, do you ensure stone clearance with any form of imaging?
At the time, it's a good question because now I am doing, and there is a comment will be there from the public that if you are doing 1 centimeter stone, if you leave 5 mm stone, they will comment. So I am doing ultrasound immediately after the stent removal. Stent removal will be done under local. Ultrasound will be done at the same time. If you are not seeing big stone, I will leave it, or else I will do relook. Ultrasound
stent removal.
Just after stent removal, within half an hour.
And stent removal will be followed by a relook if you find a stone.
Same day. Especially when I have feeling that I left something inside, more dust, large, more than 2 centimeter, always better to do relook. RIRS has low SFR than PCNL.
Do you rely on stone density preoperatively?
For laser, it doesn't make any difference, hard and large. Only thing is that too much fragile stone finishes fast. So I personally feel I don't look into it so much. I see the volume more.
So
My
what
last
is the
question,
recommended size for the flexible uroloscopy for a stone?
Sir, more than 2 centimeter, better not to take in if you are a beginner, especially if the patient should not be biased unnecessarily. More than 2 centimeter is always takes time, difficult. Water outflow logistics will be there. Sometimes fever can come. Sometimes residual stones. The cost effectiveness will decrease.
Ketan, you were asking some questions.
With combined endoscopic, truly there is no contraindication for you.
Yeah, very happy because if I have any problem, quickly I will go to supine PCNL. I am happy that I am giving higher stone free rate. That's why I change it to supine.
And for a 2 centimeter size stone, do you think your clearance with a standalone RIRS is as good as a mini perk?
If I stent and if I put mind, if I am in a calm state, if I am not in hurry, yes. 1 hour I have to take complete powder. If you do, next day CT you do, nothing will be there. But you need lot of persistence and commitment for that stone.
Believe in stone extraction during RIRS or only fragmentation?
No, I am complete duster. I don't want to use the basket at all as much as possible, except relocating. Because once you come out of the system, it will bleed or vision will disturb. You cannot come out 100 times. It is not possible. That is
Last
my
question,
version,
Mohan.
but it is controversial.
Last question. If you are using the access sheath, then why not prone PCNL and why supine PCNL? Because access sheath is anyway protruding out.
Sir, when you are turning the patient, if you do flexible ureteroscopy by chance, it is very, very difficult, sir. Very, very difficult. Prone position flexible ureteroscopy, only one case study by 1992 by Michael Grasso is there. But I tried in legs together, standing on the prone position, doing RIRS. It will be opposite and you will not be able to understand, move also.
No, no,
Very
access sheath is there. So you are.
No, sir, no. The movements when you are in supine and prone, I want to joke, in different positions doing different jobs is different, difficult. Don't think that all positions will be easy because the holes are there. It is
I'm
difficult.
not saying that my preference is for prone position, but still as a comment.
No, sir, it is difficult. We have to take opinion from Tanuj. Prone position, even if access sheath is there, movements of the flexible scope are difficult because you cannot hold the penis. You cannot hold the penis. You cannot go in between the thighs.
I agree, sir. I agree. And orientation also, we are used to orientation of supine.
Yeah, orientation is a big problem.
Thank you, Chandra Mohan.
Thank you, sir.
Go to